All right, well, we'll get started. If anybody else logs in, then we'll just sort of let them in as we go along, and we can always do a bit of a recap at the end. So my name is Jacqueline Zwambag, and I'm one of the registered physiotherapists here at EPA. I work at the Bullfrog Mall location in Guelph. I've been working here for about 10 years now, and I've taken a special interest in the shoulder, which is what I'll obviously be talking to you about tonight. If at any point you have any questions or anything like that, please feel free to jump in, or you can post them in the chat or the Q&A. I'll do my best to answer them as we go. Otherwise, I'll also give a bit of an opportunity at the end where people can ask questions if they need anything clarified that way. So just a brief overview of what we'll look at tonight. We'll look at just sort of an overview of the anatomy of the shoulder joint so we can better understand what structures can cause pain in varying conditions. This is not going to be an exhaustive list of all shoulder issues, but there are a few of the more common conditions we tend to see in clinic. I've condensed it just sort of for timing purposes. We'll also look at imaging and whether or not it's required in order to come see us. And then we'll also get into the treatment options available to you with a specific focus on surgery and physiotherapy. So if we're starting off looking at the shoulder anatomy, as some of you may know, it's a ball and socket joint. But when I often describe it to people, I like to compare it to a golf ball sitting on a tee. It's a fairly large ball and a fairly shallow socket. So it's not sitting in there nicely like you would see in the hip. The reason it's structured this way is because it gives us a lot of movement. The ligaments that surround the joint are also loose, which helps to give us a lot of mobility in the shoulder, which is great because we need it to be able to do a lot of things, reaching, all of that. But it also makes it a more unstable joint. So to try and help with this instability, we have the rotator cuff muscles that surround the ball and socket joint, and their job is to help keep the ball centered in the socket during motion. So if we're looking at this a little bit more closely, there's 4 muscles that make up the rotator cuff, which you can see in the pictures here to the right. So here with the green arrows, I'm highlighting one of the muscles, which is your supraspinatus muscle. So the top left picture here, you can see this is looking at the back of a shoulder blade. So you can see that that supraspinatus muscle with the green arrow, it sits sort of across the top back of the shoulder blade, comes across to attach onto the top of the arm bone there, over top of the ball and socket joint. The picture on the top right, that's just showing the shoulder blade or the shoulder joint from the front. So you can see again the green arrow, it's just highlighting that supraspinatus muscle as it comes across the top. The bottom picture is looking at the shoulder joint from the side. And again, the green arrow is just highlighting where that supraspinatus muscle is sitting right on top of that ball and socket joint. 2 other muscles of the rotator cuff sit on the back of the shoulder blade as well, which you can see here with the blue arrows. These are your infraspinatus and your teres minor muscles. Again, you can't really see them obviously from the top right because you're looking more at the front of the shoulder blade. But if we look at it from the side, you can see again the blue arrows are just showing where those tendons attach onto the back of the shoulder to help support that ball and socket joint from behind. The 4th muscle is your subscapularis muscle, and this sits on the front of the shoulder blade. So you can see it up in that top right picture, sitting on the front of the shoulder blade, coming across to attach onto the front of the ball and socket joint, which again, you can see down on the bottom picture, looking at it from the side, the orange arrow there is pointing to that tendon on the front. So if you're looking at that picture down on the bottom where you're looking at it from the side, you can see by the arrows how those tendons form a really nice cuff around the joint to help with the stability of that ball and socket joint. One of the more common causes of shoulder pain that we tend to see in clinic is what we call impingement. And this is essentially a condition where structures get pinched in the space between the ball and socket joint and the joint formed by your shoulder blade and collarbone that sits across the top. So this space here, which you can see in the oval, that's called the subacromial space. So that's that space between the ball and socket joint and that joint between the shoulder blade and collarbone. So within this area, there's a lot of structures that are innervated. And so when they get pinched, they can cause a lot of pain in the shoulder. Sometimes the impingement can be caused by structural changes to the joint, so things like arthritis or bony spurs. Sometimes, though, it can be a result of other issues, just like poor posture. So the way we sit, if we're really rounded, it can narrow that space and cause things to be pinched more easily. Now, if we're looking at some of the structures that sit within this area, some of the more common ones that get pinched would be that supraspinatus muscle, which you can see here again with that green arrow. So that's one of those rotator cuff muscles that comes across the top and attaches here. It's sitting in that very narrow space, and so it's likely that it can become pinched with movement if that space is narrowed even further. These structures here with the blue arrow, these are called your bursa. So we have bursa all throughout our body. I often describe them as little half-filled water balloons. They're little fluid-filled sacs that sit in areas where there would tend to be a lot of friction between bone and tendon, and they're there to try and help minimize that so there's less wear and tear on the tendons. Now, these tend to be softer and more fluid, but when we have things like impingement happening and they get pinched and irritated, they become a little bit thicker. They can become a little bit more leathery. And again, that can cause a lot of pain in the shoulder. One of the last structures, there's still other ones, but one of the other main structures that can get pinched in here would be your bicep tendon, which you can see with that yellow arrow. So that tendon runs all the way up and into the shoulder joint itself. And again, it's sitting within that area where it could easily get pinched if that space is narrowed. Oops, sorry, one sec. So some of the symptoms people might complain of if they have impingement, they often describe having pain when working at shoulder height, reaching overhead, reaching across the body like this, or reaching with their hand behind their back. Pain can sometimes radiate as far down the arm as the elbow. So a lot of times when people come in, they complain of pain being through the arm here, not necessarily isolated to just the shoulder. So even if you're feeling it here, it could be originating from that area. A lot of people have pain while sleeping on that side, or they have pain and or weakness with lifting, pushing, or pulling activities. A lot of clients also come in with something called tendinitis or tendinosis. These are conditions that can affect any of the 4 rotator cuff muscles. So oftentimes it's more than just one tendon that's involved. It can be just one, but oftentimes we'll usually see a couple that are affected by this condition. More often than not, it's that supraspinatus tendon that's affected. So again, that one that runs across the top of the shoulder. And because it tends to sit within that narrow space at the top of the shoulder. It also tends to have a poor blood supply, so it's more likely to be affected by these conditions because it doesn't have a great ability to heal itself. We tend to see these conditions in a lot of people who do repetitive overhead activities, and it's more often than not seen in those who are over 40 years of age. This happens because we tend to see the breakdown of the tissues and the tendons just with the general aging process. So they don't have that great ability to heal and recover as quickly as we may like. So then they can progress into more of these tendinitis or tendinosis conditions. When I talk about tendinitis or tendinosis, these are 2 different conditions. They're not necessarily one doesn't necessarily lead into the other. Tendinitis is more of an acute condition. You see a lot more inflammation involved with this one. So if we were to look at the tendons under a microscope when there's tendinitis, you wouldn't necessarily see any changes happening to the tendon when we look at it at that microscopic level. The tendon as a whole is just inflamed and irritated. Tendinosis is a more chronic condition, so something that's been lingering for a little bit longer. And when we look at tendinosis, there's actually no active inflammation happening at that point. This is not a great thing. Inflammation is actually a good thing, which we do want because it helps to promote healing and regeneration in the body. So when there's no inflammation happening, then we see a lot more sort of degeneration of the tendon. So that's when we would see things happening at a more microscopic level. You would see that the tendon is thickened and has a bit more of a scarred appearance. So tendinosis tends to be a little bit slower of a recovery just because it is something that's a little bit more chronic and has been lingering for a while. Symptoms that people complain of when they have tendinitis or tendinosis, they'll often have similar symptoms as with impingements. They'll have pain with raising the arm overhead, reaching across the body, or reaching behind the back. They'll have difficulty sleeping, or the pain may wake them at night. This one's a little bit different from the other. You'll see more stiffness in the joint and decreased mobility and strength of the arm. The pain can also radiate down to the elbow, and there will also be some pain with lifting and pulling, and we tend to see a bit more pain at rest with these individuals. Rotator cuff tears, these are another one of the more common conditions that we see that'll affect the shoulder joint. It can affect any of the 4 rotator cuff muscles, and it's not always just one that is torn. Much like with tendinitis and tendinosis, we tend to see the supraspinatus, so that one again that sits across the top of the shoulder joint. It's the one that's more often involved, again, just because of its location in that narrow space. Tears can be due to trauma, so it could be from a sports injury, lifting something that's too heavy, falling onto the shoulder, or falling onto an outstretched arm. But these things tend to happen a little bit more in younger individuals. So more often we'll see these in people under 40. A lot of times we'll see people coming into clinic with what we call atraumatic tears. So these are just more the result of wear and tear and the general aging process. As we age, the tendons of the rotator cuff tend to suffer from decreased blood supply, which means their ability to heal themselves is impaired. So over time, this degeneration can lead to fraying of the tendon and then ultimately a tear. Atraumatic tears, they're found in the research to be present in up to 54% of the population between the ages of 60 and 80 years of age. So they are quite common. Tears can be described as either partial thickness or full thickness tears. Partial thickness tears, they're diagnosed when there's damage to some of the layers of the tendon, but some layers remain intact. So think of it as a rope that's fraying. So part of the rope is still intact, but parts of it are sort of wearing and tearing away. So an example of that, it would be the picture down on the bottom right. You can see that part of that tendon across the top there is fraying, but it's not a tear that goes all the way through the full thickness of the tendon. A full thickness tear, which you can see in the top picture on the right, these are characterized by the tear going all the way through all the layers of the tendon. It doesn't necessarily have to go all the way across the full tendon, but it goes all the way through the thickness of it. So that area of the tendon is no longer fully attached to the bone. And so this tends to be a little bit more of an issue when it comes to tears. Again, symptoms of a rotator cuff tear we tend to see in clinic. Again, people complaining of pain and weakness with raising the arm overhead, reaching across the body or behind the back, pain in the shoulder at rest and at night. There's again pain and weakness with lifting and pulling, We'll see usually a decreased range of motion, and sometimes people might complain of clicking or popping with moving the shoulder. I have down here at the bottom, though, one of the more important things to note is that it's very possible to have a tear in the rotator cuff and not have any pain or symptoms. There's a lot of people walking around that have tears, don't even know it because they're able to move their shoulder without problems. They don't have pain. They don't have any limitations. So it just goes to show that it is possible to carry on a normal, functioning, pain-free life, even if there is a tear. We'll discuss this a little bit further when we get more into the treatment side of things, but it's just a really important thing to kind of keep in the back of your mind. One of the last conditions we'll discuss here is frozen shoulder. So this is one, it doesn't necessarily involve the rotator cuff. This is involving more of the ligaments and the structure that surrounds the ball and socket joint that we call the joint capsule. So in the bottom left picture, you can see that white that surrounds the ball and socket joint. That's what we call the shoulder capsule. It's sort of helping to hold the ball and socket together. In frozen shoulder, the capsule, which you can see sort of in that top left picture, it tends to become inflamed and it shrinks and then becomes stuck to itself. So this will result in severe limitations of range of motion, and it's very, very, very painful. It can happen spontaneously, or it can happen as a result of something else. So a lot of times we see this as a secondary thing because someone's gone and injured their shoulder. They stop moving it because it's painful, but because they're not moving it and they're keeping it protected that way, then that capsule starts to get irritated and shrinks and stiffens up. As I said, it can happen spontaneously. It's one of those ones that's not really fully understood, but some of the risk factors for spontaneous occurrence, it tends to be more common in women. Up to 70% of cases are female. And with that, it tends to be more present in postmenopausal women. So there's a thought that it's related to the changing hormones and the change in estrogen levels. Diabetes is something that can also increase the risk for this. Again, it has to do with the blood supply to the joints. It can really heighten that risk. Hyper or hypothyroidism is something else that can increase the risk of this, as well as cardiovascular disease and Parkinson's disease are some of the other ones that increase the risk for frozen shoulder. Frozen shoulder usually presents, it has 3 stages. The first stage is our freezing stage, and this is when most people will start to come into clinic and seek treatment. They start to notice changes in their range of motion, and they're also suffering from usually very intense pain. Once it's worked through the freezing stage, it gets to what we call the frozen stage. This is the middle stage where you'll see the most restriction in movement. Pain may remain the same. Sometimes it improves a bit. It's more that we see a lot of stiffness of the shoulder joint in this stage. After that, it progresses into the thawing stage, which is the final stage. You'll see the pain lessen and the range of motion will gradually improve. So it is a condition that does sort of resolve itself, but it takes a long time. On average, it can take 2 to 5 years if it goes untreated. And again, it does resolve, but it's not guaranteed that it will fully recover if you just leave it be. So it's still good to come in and get it looked at, get it treated, because it may not necessarily come back to 100% without treatment. Sometimes shoulder pain may be the result of other areas causing the pain as well. A lot of times we'll see the neck can refer pain into the shoulder area. Often the joints and the muscles and the nerves through the bottom of the neck can send pain down into the shoulder blade area. So this is something that, again, we can kind of tease out in our assessment and figure out more specifically kind of what the cause of your shoulder pain is. So a lot of people always ask, how did I get the shoulder pain? What did I do wrong? Again, it's not necessarily that there was anything done wrong. It's usually a combination of overload of both physical and lifestyle factors. Research has shown that the single biggest risk factor for developing shoulder pain is turning 50. So again, this is just because as we age, the tendons don't tend to have a great blood supply and they don't bounce back and recover as easily as they can when we're younger. The second biggest risk factor for developing shoulder pain is having diabetes. Genetics are important, and also the number of comorbidities, so things like stress, anxiety, not sleeping well, smoking, being overweight, those types of things can really impact whether or not we develop shoulder pain as well. Hormones, again, if we kind of think back to the frozen shoulder, hormonal status can play a big impact. So estrogen, especially in obviously women, helps to protect against some of these shoulder conditions. So everybody always asks too when they come in, you know, do I need imaging? Should I go get an MRI or X-ray, ultrasound? You know, what should I get done? And you don't need to have imaging done, especially to come see us. If you remember from a few slides ago, I mentioned tears of the rotator cuff are present in up to 54% of the population between the ages of 60 and 80 years of age. And a lot of these tears are asymptomatic. So people aren't having pain, they're not having range of motion limitations. So a lot of times when people have imaging done, the injuries that are showing up are more just due to age-related changes than an actual issue that happens. So, research has shown that people who have symptomatic tears, the size of the tear does not always correlate with the level of pain. So a larger tear doesn't always equal more pain. So it's really important to note that if you have imaging done, the picture that you see doesn't always match up with the symptoms. I like the quote that's off to the right here it's a physiotherapist who's fairly big in the shoulder field. She was saying that if you take 100 scans of 50 people with shoulder pain and 50 without, and then were to just give those pictures to a radiologist, they wouldn't be able to tell you which group had pain. So it just sort of reiterates that, you know, these images, they can be helpful, but they also don't necessarily give us an answer. The graph as well to the right is just from another study where they took images of people's shoulders. So people were coming in complaining of pain. They did an MRI of their painful shoulder as well as an MRI of their other shoulder, which was not painful. And then you can see that there was really no significant difference in MRI findings from side to side. So between the painful shoulder and the non-painful shoulder, there was really no difference when they were looking at, you know, rotator cuff tendonitis or tendinosis or the tears, those types of things. So there really isn't a need to go rush to get the imaging done because it doesn't really give us a lot of helpful information. It's usually something that we'll kind of consider later on down the line. You know, if you've tried some physio, it's not necessarily improving, then maybe we'll consider the imaging to see if there's anything else going on. But we have a lot of clinical tests and things that we do here that are reliable and kind of offer us a bit more useful information than maybe an ultrasound, X-ray, or MRI might. So in terms of treatment options, there's sort of three main treatments to consider. Injection being one, surgery, but it's important to remember that surgery is not just a standalone treatment. It's always followed by a period of immobilization, as well as some lengthy rehabilitation. Another option, obviously, which we tend to encourage is rehabilitation just on its own. So that would be coming in for physio and doing your exercises, just that alone. If we look more closely at injections, this really isn't the best first line of treatment. One of the few instances where it may be of consideration is if someone comes in and they have that really painful freezing stage of frozen shoulder. That's one of the instances where it sometimes might be of benefit. But overall, when people are coming in with just like a tear or tendonitis, those types of things, The injections have really only been shown to reduce pain for 1 in 5 people, or 20%. So in other words, if you're looking at the picture to the right, injections are only going to help the people that have the green faces, not the red faces. So it's not a huge percentage that find a benefit from this. And even at that, the people in the that fall into that green face category, it's not always a full relief of pain. It's going to be partial or even, very, very minimal relief of pain. So it's not necessarily a great way to handle treating the shoulder. Those who have an injection, when they do have some benefit from it, it only lasts for about 4 to 8 weeks. So again, it's not a very long-lasting improvement. It's also important, they found in research, to keep the injections to a minimum. It suggested that you really only ever have one injection. The studies have shown that when they did more injections, there was no further decrease in pain when they had multiple injections versus just having one. They also found that injections, these steroid injections, can increase the risk for needing surgery, and they can also accelerate tendon and cartilage degeneration. So that's, again, a reason why it's better to kind of hold off on them if you can, and sort of use this as a bit of a last resort. A lot of people now who have rotator cuff tears that they've found on imaging, they feel that surgery is really their only option for recovery. This really isn't the case. Surgeons are often looking for patients who have failed to respond to physiotherapy. So, let's say you've gone to your family doctor and you've got the imaging, there's a tear. Well, the doctor may wait to refer you to see a surgeon until you've given physiotherapy a quote unquote good go. So that's usually at least 12 weeks of, attending physio, doing exercises. Even if you do end up needing surgery, research has shown that those who engage in physio beforehand have been shown to do better at 6 months post-op. So, even if you're coming in, you're doing your physio, you don't necessarily respond, and you do end up having surgery, you're still going to be in a better position had you not done anything prior to surgery. Surgeons are looking for people who don't respond to physiotherapy and have pain as their primary symptom. And usually, too, they want to see the imaging has to show that there's a large enough tear to warrant repair, and the tissue has to be of good quality. So sometimes, again, because as we age, our tendons tend to degenerate, and they're maybe not necessarily the best condition for surgery. It's almost like trying to stitch together wet newspaper. They can go in and they could do the repair, but it's not going to necessarily last. So these are all things that the surgeon will have to consider as well when they're looking at who they're going to do surgery for. There's no guarantee that surgery is going to resolve the symptoms. In fact, research has shown that people who have had surgical repair, there can be a high frequency of re-tearing. It can be up to 90% of people re-tear after surgery. And again, the higher rates of failure, these are typically associated with individuals who have more of those degenerative changes in the tendon. So again, when I said it's almost like stitching together wet newspaper when things are more degenerated in there. So those are the people who tend to have poorer response to surgery. But the one thing to note actually is that if you do have a re-tear, they found in the research that those people who have had re-tears, they still report higher quality of life and less pain than those who whose tears remain intact. So it just goes to show that again, there's sort of a lack of correlation between the structure of the shoulder tissues and function. So it may just mean too that maybe surgery is more of just a placebo effect for these individuals. So again, something to consider when you're thinking, do I need surgery or not? Also remember that, again, surgery, this is going to be followed by a long period of immobilization. So usually you're in a sling for about 6 weeks, not able to move the shoulder. You can't drive. Depending on your work, your job, you may not be able to actually do much work within that 6-week time frame. And then you're also going to be doing at least the same amount of rehabilitation as if you didn't have surgery. So it's just important to remember that surgery is not a standalone. It's still going to be a very lengthy recovery when it comes to the shoulder. So this is just a slide showing a bit more research supporting the use of exercise, showing that it can be just as effective as surgery for individuals. Looking specifically at those with impingement, it was found in studies that exercise can reduce the need for surgery up to 80%. And when they looked at these individuals, 1, 2, 5, and even 10 years follow-up, it was, again, found that exercise was just as effective as surgery. Another study looked at some of those non-traumatic partial thickness tears. So these are the ones, again, where you think more of the tendon kind of fraying as a result of degeneration. And they were looking at people who had up to 75% of their tendons torn. And they found that at 1 year follow-up and 2 years follow-up, there was no difference between those people who had surgery and those who did just exercise. Again, it's just suggesting that exercise and non-surgical management is a really good first step when it comes to treating these partial thickness tears. Another study looked at full thickness tears and found that exercise significantly reduced the need for surgery up to 75%. This was at a 2-year follow-up. And they found that even those who had traumatic tears, so tears as a result of, a sports injury, a fall, those types of things, only 40% of them needed to go on to have surgery if they did exercise first. So it's just going to show that as physiotherapists, we're offering some of the best treatment when it comes to shoulder pain and injury, and it's a very good first step in the management of rotator cuff related shoulder pain. So, if you're having shoulder issues, don't hesitate to come in because it's all going to be beneficial in the long run. So what we might do when we see you in clinic, we would obviously go through an initial assessment where we would do tests and things. We'd go through range of motion and basically try and see if we can pinpoint a little bit more specifically what is causing your shoulder pain. And then from there, we would go into our treatment. So we would use a combination of education on the condition to try and help, and how to try and help minimize flare-ups so that you're not having significant pain. We use things like tape and other modalities, so ultrasound, IFC, TENS. Some of us do acupuncture. We use heat, ice, all those types of things to try and help manage the pain. And then we'll get into as well some of the manual therapy or hands-on techniques that we use to try and help improve range of motion, help decrease any tension of the surrounding muscles to help with pain and all of that as well. But then the biggest thing that we'll give you are exercises to help with, again, increasing shoulder mobility, strengthening of the remaining healthy rotator cuff and surrounding shoulder musculature, as well as providing ongoing follow-up. So a lot of times we'll have people as well who come in, they improve and recover, but then they sort of come in every now and then just to kind of check in, make sure things are still going well. So that's something else that we offer here too. A lot of people ask, what can I expect? How long is it going to take? So on average, it's about 12 weeks for us to see disability reduce. Some people may be quicker, some people may take a bit longer. It depends on condition, age, and other factors. The other thing to note is it's very, very common to have, and very normal to have, some ups and downs and setbacks along the way. So if you're looking at this graph to the right, you can see we have an arrow, descending down. That would obviously be our ideal trajectory for your recovery. We would love to see it just be a perfectly linear recovery. but it's really going to be more like that squiggly line. You're going to see, you know, flare-ups and little setbacks along the way. That's all completely normal. It's really important to remember that increased symptoms, so if you have a little bit of a flare-up, these increased symptoms does not imply that you've done harm to the shoulder. So, you know, we have a lot of people who come in and they get really worried that they've, you know, made things worse. No, you usually haven't. It's just that we need to tweak your exercises or things a little bit. Maybe we just pushed it a little bit too much. Things got a little irritated, but it doesn't mean that you did more damage. The worst thing you could do and the most harm you could do would just be not moving the shoulder at all, not exercising, because again, that's when you can start to progress into more of that frozen shoulder, which again is very, very painful, very, very stiff, and it takes a long time to recover. So the best thing is to just try and keep it moving and work on building up that strength. We're working together, you know, to get you to the best possible outcome we can get. Trying to get that pain and that disability down to a level so that you're leaving, you know, hopefully saying, oh, I never thought I'd be able to do that again, you know, trying to get you doing whatever it is you need to do for work, day to day, all those types of things. Everybody always asks too, you know, how long do I need to be doing the exercises for? Well, short answer is try to do them forever. They don't necessarily need to be the same exercises that we've given you, but you need to be doing some kind of physical activity on a regular basis in order to maintain the improvements that we've achieved. So as soon as you stop doing physical activity, that's when you start to notice changes in symptoms and you'll start to see things start to kind of come back. So short answer is you keep doing the exercises long term, keep going forever, but again, it doesn't necessarily have to be all of the exercises we give you in clinic. That's something you can kind of discuss with your physio as you go along. You can see as well, I've got an arrow here showing lifestyle factors and how that can influence the recovery. So these are things, again, like smoking, poor sleep, if there's a lot of stress or anxiety in your life, poor diet, being overweight. These are all things that can also prolong symptoms. And so it's really important to consider these as well in the process of your shoulder recovery, because none of the treatment options will have the benefit you want if you're not also sort of helping to address and reduce the impact that these other factors are having on your symptoms. So just something as well to keep in mind throughout the process of your shoulder recovery. So just a quick summary of a few of the key points that I hope you take away from this presentation. Obviously, the shoulder is a very complex joint. There's lots of different structures that could be causing your pain. So that's where we as physios can help. Again, even if you haven't had imaging, as I said, it's not really necessary. We can do a lot of things in clinic to identify what might be causing the pain. And again, big note with the imaging is just to remember that even if you have had it done, don't get too hung up on it because the picture doesn't always match the symptoms. And then again, one of the bigger things to note is that most individuals, so 75 to 80%, can experience a full recovery in terms of pain, mobility, and strength with just the conservative management, so physio and exercise, and that's even if there is a tear. So basically, don't wait to come in if you're experiencing shoulder pain. Come in, we'll take a look, we can, you know, assess and figure out what the best steps are going to be for you. So thank you everybody for tuning in who did. Now, if you have any questions, you can feel free to ask. Otherwise, if you're sort of wanting to just digest all the information, I know it was a lot, you can feel free to kind of just take it in, but don't hesitate to reach out. As I said, I'm at the Bullfrog Mall location. You can give a call to our clinic. I'm more than happy to get back and chat with you more on the phone if you feel more comfortable doing that as well.